Hi, I am Jeanne Schumacher. Welcome to Women's Health. Debra and we founded the Pregnancy Advantage. This is where we can help women to get their bodies pregnant ready, or help if you're having trouble conceiving, especially before you go down that in vitro fertilization rabbit hole. So today my partner is Dr. Debra Shapiro. She's a board certified OBGYN. And today we're going to continue our conversation on breast cancer because first of all, it's Breast Cancer Awareness Month, of course, but it's a big topic and huge. So Debra, take it away. You ready?
Yes, absolutely. And thanks for joining us again. So we have four weeks to talk about breast cancer awareness and prevention this month. We've spent a couple of weeks talking about steps that you can take to prevent breast cancer. Today, we're going to be talking about screening for breast cancer, particularly mammography. And I have to say that I learned a lot over the last couple of years and about mammography, its risks and benefits. And it was very different than what I was taught in my residency, and very different than I've been telling people over the last number of years too. So we've all had to grow and accept sort of this almost like an inconvenient truth or an uncomfortable truth about breast cancer screening. So here we go. Next week, we're going to go back to more about prevention, but now we're going to be talking about mammograms. So we're going to be talking about cancer screening as a preventive measure in public health, the widespread use of mammography as a breast cancer screening tool, screening recommendations, both here and abroad, benefits and risks of screening for breast cancer. And you're going to understand something called lead time bias and overdiagnosis bias. And we'll review some additional modalities for diagnosis, such as MRIs and ultrasound. And I'll also tell you a little bit about the thermography. There's some interest in that. I have to say how this all started for me. I attended my first International Plant-Based Nutrition Healthcare Conference about 7 years ago. And I ran into a colleague of mine who works down in Santa Cruz. And he told me that from what he had read and learned, that mammograms caused more problems than they prevented. And his wife was never going to get a mammogram. And I was skeptical, to say the least. I mean, really, you could have pushed me over with a feather. I had never heard this before. So I went back to some of the data that was now being presented at that time by Dr. Michael Greger in a multi-part series on mammography that's on nutritionfacts.org. So if anyone really wants more of a deep dive into all of this and get all the sources, they can definitely find it on nutritionfacts.org. There's a whole, I don't know, it might be about 10 or 15 parts on mammograms, maybe 10. And I checked the resources that he cited, and our own NIH and the National Cancer Institute, and I started to come to terms with this uncomfortable truth. So ACOG, the American College of OBGYN, does recommend mammograms offered to all average risk women starting at age 40, every 1 to 2 years until 50, and then yearly. And I have radiologist friends and colleagues all actively promoting regular breast cancer screening. And we're constantly hearing the meme, early detection saves lives using mammography. And I just want you to know that the American College of Radiology actually owns the trademark mammography saves lives. So just a little taste of, that there's some money involved here, a lot of money. So it's interesting that there are inconsistent guidelines about mammography. The U.S. Preventive Services Task Force, they recommend biennial, that means every 2 years screening, starting at 50 and just continuing to age 75. And the American Cancer Society changed its recommendations to start mammograms yearly at 45 and then decrease to every other year at 55. So really different, right? So then to go to every other year at 55 when ACOG says the opposite, to do every year. And stop when life expectancy is 10 years or less. Just to put this also in some other perspective, in Switzerland, there's no recommendation for routine screening at all. And there is controversy about when to start and when to stop as well. The American College of OBGYN says maybe to stop when life expectancy is sort of about 5 years, or maybe when a person is considered to be, too ill to have the treatment for breast cancer. And the U.S. Preventive Services Task Force says to stop at 75. So let's just talk about screening in general. It sounds like a really great idea, right? So since breast cancer is the second most common cancer in women after skin cancer, and breast cancer is the second most common cause of cancer death after lung cancer, the number one cause of death, though, is still heart disease. So you should keep that in mind. A woman's lifetime risk of breast cancer is about 1 in 8, or 12.5%. 40,000 women are dying annually from breast cancer, and 4 million women in the United States actually have breast cancer. So screening, a good screening test ideally would detect early stages of cancer and reduce mortality. Because if you catch it early, you think, well, you're going to be preventing those early cancers from progressing. Screening does work for cervical cancer and colorectal cancer. As an OBGYN, I would remove an early stage precancerous lesion of the cervix, and that would definitely prevent that lesion from progressing and causing cervical cancer. And you can see that in the data. So screening tests, as defined by our NIH and National Cancer Institute, the National Institutes of Health, this is checking for disease when there are no symptoms. Since screening may find diseases at an earlier age, there may be a better chance of curing the disease. And so it's implied that if we find early changes in the cells and we remove them, you prevent progression to more advanced cancers. And examples of this were, I was talking about cervical cancer, but also colorectal cancer. If you remove precancerous adenomatous polyps during a colonoscopy or a sigmoidoscopy, the incidence of colon cancer is definitely reduced. But now contrast that with screening men for prostate cancer with yearly PSAs, prostate-specific antigens. Not so fast, right? If you check out the American Cancer Society's page on can prostate cancer be found early, it's very different. They're very clear about overdiagnosis, false positives and negatives, and potential harm, which is really different from the way they talk about breast cancer. So let's see, is it different or is it similar? What is breast cancer more like? Is it more like prostate cancer? Or is it more like cervical cancer? So just some backing up, we have something called stage 0 breast cancer, which is DCIS, ductal carcinoma in situ, and it makes up 20 to 25% of breast cancer diagnoses. But we remove 50,000 to 60,000 DCIS lesions annually, and this has not been accompanied by a reduction in the incidence of invasive breast cancer. Your lifetime risk of death from breast cancer is 4%. It's the same as a man's risk of dying from prostate cancer. In the UK, they said that 30% of DCIS treated with mastectomy and 24% of invasive cancer is treated with mastectomy. They're finding more stage 0 and stage 1 with all the screening. There's more surgery, but actually there's no less stage 2, 3, and 4 being found, which is very different than what we see when we treat cervical cancer early and cervical precancer early and dysplasia early. So the bottom line is we don't know enough about the natural history of DCIS, which lesions will progress and which will regress or remain indolent. And I think I was always taught that it would be the same as with a precancerous lesion in the cervix. And we know about the natural history of cervical dysplasia and cervical cancer, but we don't know about the natural history. We don't know enough about what happens to these cells, which ones are programmed to become aggressive and to grow and to duplicate, multiply, and which simply outgrow their blood supply or they're starved, which ones are targeted by our immune system and taken out and destroyed. And some just weren't very aggressive in the first place. But this overtreatment leads to a lot of extra surgeries, and we'll talk about that. So what's interesting is is that the women who are possibly harmed the most claim the most benefit. So if you talk to someone who had a mammogram, they found a lesion, she had her surgery, and she went on and lived, she will tell you that the mammogram saved her life. But in fact, when you look at the data, when they look at low-grade DCIS and the 10 years cancer-specific survival, it's 98.8% if there's no excision and 98.6% with surgical excision. So really, whether you treat DCIS with surgery or without, there's no difference. And there's other data that you can find. If you want to look in the New England Journal of Medicine, it's from 2012. It's volume 367. And they're looking at the mammograms in women over 40 and the amount of the incidence of early stage cancer has risen tremendously as screening protocols have increased and everyone's getting screened. But the late stage cancers have remained about the same. There has not been a significant decrease. I mean, you expect early stage cancers go up. Well, we're going to prevent women from dying of breast cancer. And in fact, it's just not happening. So there's this Cochrane review, which I would also definitely recommend. The Cochrane Reviews are wonderful reviews of lots and lots of data. And the bottom line is screening does not seem to make women live longer, but it increases mastectomies. Cancers are not caught early. They're all caught very late. They're also caught in too great numbers. And there's much overdiagnosis that the best thing, and they feel like the best thing a woman can do to lower her risk of becoming a breast cancer patient is to avoid going to screening, which will lower her risk by a third. And there's an information leaflet, which you can find at www.cochrane.dk. And that'll make it easier for women for you to make an informed decision about whether you should go for screening. There's also a journal in the Journal of the Royal Society of Medicine from 2015, which talks about this as well. But this is all very important stuff because, we've really been fed this information that, you've got to find breast cancer early to improve survival. And it just isn't really true. Is there any harm to screening other than just overtreatment of low-grade lesions that wouldn't progress to cancer? Yes, there's false positive mammograms. So the report is suspicious and more testing is recommended. I mean, how many of you have had that? Where you go for a mammogram and they see something and then they want you to come back and get compression views. And then they say, well, maybe you need a biopsy, and you have a biopsy and then it's really nothing. So false positive. So when they look at 2,000 women, 1 woman will have her life prolonged, but 10 will be treated unnecessarily because of the nature of breast cancer, because we know that many don't progress, and 1,000 will have false positive screens leading to more procedures. 1,000. So again, if you look at 1,000 women screening, 1,000 women screened and 1,000 women without screening, and you start at 50 and you do every 2 years for up to 20 years, 1 life out of 1,000 screened is saved from breast cancer, but there's no change in the number of women who died from any cancer. No change in the number of women who died from any cancer. And many women underwent unnecessary procedures. So there's this wonderful site. It's called the Harding Center for Risk Literacy. And you can find that under Harding Center. If you screen 1,000 women, they compare 1,000 women who were screened and 1,000 women who weren't screened. There is 1 more person who is found to have breast cancer and who died of breast cancer, who would be saved if she had screening. But the number of women who died of any cancer is the same. And there are 100 more biopsies and alarms and unnecessary procedures. 5 women in the group that's screened will actually have a removal of part or all of her breast. So the interesting thing about screening is about the psychological harm. I mean, I know how you feel because I've been in that room shivering, with fear, with all those other women worrying, are they going to find something? Is this going to be the year that, the shoe drops? We all go through that. And so they've done some data. They've looked at this and they said after 6 months, only 64% of women thought they were cancer-free. So just 64% of women after 6 months. And at a year, it's still not 100%. After 1 year, only 90% felt they were well. And after 2 years, 100% felt they're well. But of course, now it's time to rescreen, right? So women with a false positive experience, with a false positive result on a mammogram, experience psychological hardship for up to 3 years. They have lower quality of life, more clinic visits, and less trust in the healthcare system generally. Let's just look at some real numbers. And I actually got this from a wonderful book called Breasts, an Owner's Manual by Christy Funk, Dr. Christy Funk. It's a wonderful book. And she takes a very measured approach about breast cancer screening and a lot about prevention. So I do recommend that book as well. So let's say you have 60,000 cases of DCIS, that's stage 0 breast cancer. I don't know how many of you had that, how many of you have friends who've had that and had treatments. Usually they have excision, radiation, and 5 years of tamoxifen, and they're pretty miserable with all of that. Well, it's just okay. But a lot of women actually have both breasts removed. So 20% of these women will be overdiagnosed. They're not going to progress. That's 12,000 women out of the 60,000. And that's probably a very conservative estimate about overdiagnosis. 20% will be overdiagnosed. 12,000 women. 30% of these women, 30% of the 12,000 will choose mastectomy, which is 3,600 mastectomies, unnecessary mastectomies. And 400 of those women will want both of their breasts removed because they're convinced that something horrible is growing inside of them, which is going to move to the other breast. So they might as well just take both breasts off at once. And
well, wasn't there the pop star, I forget whatever kind of star, she had the double mastectomy to be proactive. She had no issues, no problems. And she had the double mastectomy.
There was no family history. It wasn't a BRCA because
she had that gene.
Yes.
She had that gene, and she was being proactive and had both her breasts removed. And I'm like, are you kidding me?
Well, she's someone.
Are you kidding me?
She doesn't believe in the power of prevention, but which we've talked about before, exercise and diet and maintaining a healthy weight and not drinking alcohol and having more soy and all the different foods that are helpful. But if you're going to live on, bacon and sausage and lots of alcohol and have that kind of life then you might think about it. But right. So that's 4,000 unnecessary mastectomies per year for DCIS alone. And that's what happens. But it will not change anybody's mortality overall. The same number of women will die. What about false negative mammograms? This is what doctors fear the most because we can be sued for missing a cancer. So you have a normal mammogram, right? It's red is normal, but there's an interval cancer is detected. And we think that it's missed. So 35% are missed by the radiology. They're overlooked by the radiologist. 65% were not visible on the prior mammogram. But honestly, there's no poorer prognosis than if they were detected on screening. That's what the data shows. And it really gets to the heart of the issue. So lifetime progression of DCIS to invasive cancer is less than 50%. And we don't know what happens to every collection of abnormal cells. What might cause a false negative mammogram? Dense breast tissue. It's very common premenopausally, which is why the U.S. Preventive Task Force doesn't even recommend that women get mammograms before 50. Breast implants can also cause a false negative mammogram where we miss something. Tumors at the edges of the breast that are hard to visualize, and hormone replacement therapy, the estrogen, which makes the tissue more dense, and poor imaging quality. And are there any other harms from screening? So there are, and I didn't really know about this either, but there's a 27% increase of death from heart disease because you're radiating inside the chest. And there's an 80% increase in lung cancers. There's even a small increase in breast cancer as well.
I did not know that, Deborah.
Yes.
And oh my gosh, to me, that just is insane that we're increasing all these other risk factors. And for what? And oh my God, I remember the last time I had a mammogram, and I will not have another one ever again in my lifetime. But I remember the last time, and she literally took my breast tissue and it's not a pleasant experience. And the tissue ripped. From, how when she was pulling the breast, and she just literally, and I felt something go tear, and I'm like, oh my God, and the pain. And it was it hurt. It really hurt a lot.
They are painful. They are painful. But so, how I've always said this to people. I have definitely said this to people that we need to catch cancer early. We need to catch breast cancer early. And you'll still see it in all the literature, early detection. Remember that the American College of Radiology owns that, that little meme. But breast cancer has been growing. We're not catching it early. Breast cancer has been growing for about 21.4 years before it's caught on a mammogram, and just a little bit longer without a mammogram, 22.8 years without a mammogram. You're going to, the changes between being palpable and not palpable is a very small number of changes when it gets to that size.
For example, I was taught to do my own breast exam, okay? I'm no specialist, okay? But how can I tell, some of the breast tissue in there, what you were talking about, the dense tissue, and it's it's got these lumps in there. And how am I supposed to distinguish between a lump and a cancer? That's just a normal lump and cancer. Really?
Right. So that's another change. We used to tell people to do breast self-exam, and I used to go to all Great Lakes to teach people exactly how to do it, right? Go around. We used to give them little things to put in their showers. But now that's all changed. Even the American College of, I think even the American Cancer Society agrees now that we should not be teaching breast self-exam and not be recommending breast self-exam.
Because my breast tissue never was because they always have a sample. Can you feel the little tumor inside? My breast tissue never felt like that, no, mine's different, And if you had to ask me, I would have said, oh my God, I'm filled with it, because it felt like I had all those little things inside my breast tissue.
Right. Very few people have that kind of homogeneous tissue where you can actually feel, right. Yeah. But mostly when it's fatty replaced, but certainly in a young breast, it's got lots of glandular tissue and fibrous tissue and cystic tissue. So yes, we just tell women now to be generally aware I mean, I don't want you never to look at your breasts. You have to be aware if there's asymmetry, if there's skin changes, if there's a discharge, but you don't have to go around in a certain particular way every month, and you shouldn't, because it just does more harm. And I do have some information about that as well. So really this understanding that breast cancer has been growing for decades before it's detected by any means. And that's why we always recommend prevention. There were two things that I wanted to try to explain before we wrap up. But one is lead time bias, because the reason this is important is because you're going to be reading about something called the 5-year survival rate and how we increase the 5-year survival rate. Cancer is starting at a particular age. Let's say cancer starts at 40. It's found because of symptoms at age 67. And then the woman dies at 70. So her 5-year survival is 0, right? 0%, because the tumor was found at 67 because of symptoms. She saw something or felt something, and then she died at 70. So this 5-year survival is 0. But what if the tumor starts at the same time growing in her, but it's diagnosed because of screening at 60? So the tumor started growing at 40. She found it on a mammogram at 60, and she still died at 70. 5-year survival is 100%. So that's how they're able to say, we've just taken their 5-year survival from 0 to 100%.
Smoke and mirrors.
But you'll hear that, you'll see that. And the other kind of bias that we see is overdiagnosis bias. And that's where we take 1,000 women without screening. So they have progressive cancer and it's found, right? And at the end of 5 years from when it's found, 400 are alive and 600 are dead. That's just the way it is, right? That's the 5-year survival is 40%. But what if we add screening and we add 2,000 people to that 1,000, 2,000 people who have non-progressive cancer. So now we have 3,000 people. And at the end of 5 years, the same number are alive. 400 are alive, 600 are dead, but you added 2,000 more who were screened with non-progressive cancer that was never going to do anything. Now you can say your 5-year survival is 80% because you have 2,400 alive and the same 600 dead. So 2,400 over 3,000 now is 80%. So now you've doubled your 5-year survival because of overdiagnosis. I think it is interesting. The American Cancer Society treats men very differently than women with regard to this kind of risk assessment for yourself. So we discussed that the mortality for breast cancer is about the same as for prostate cancer, about 4%. And both cancers share many of the same issues with screening, overdiagnosis, right? False positives. So the American Cancer Society tells men to weigh the evidence. But the American Cancer Society simply tells women to get mammograms regularly, as if women can't really handle the uncertainties. And I find that very disturbing. But breast self-exam, we were just talking a little bit about that. The U.S. Preventive Services Task Force. Since 1984, they have been the gold standard for preventive care recommendations. They are not biased by any personal gain. It's not the radiologists, blah, 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 people who own these who make these machines. So they recommend screening mammograms for average risk women from 50 to 79 biennially, every 2 years, but no teaching or recommendations for breast self-exam. This appears only to do harm. It doubles the biopsy rate. This is very sad. So please look at this book, Breasts: An Owner's Manual by Christy Funk. She still does recommend breast self-exam, but a more moderate approach, I think, might be just to recommend breast awareness. So there's no right answer about screening. I'm not trying to tell you not to do it. You have to do what feels best for you, given your own personal history, your family history, and risk factors. What we've just been talking about is regarding average risk women. So you can weigh the risk and benefits for yourself. We did want to talk about a few tips for best screening. If you're under 50 or you have dense breasts, please ask for the 3D tomosynthesis. It's better than the 2D. So instead of just compressing and taking one big picture, to smashing the breast, taking a picture, what the tomosynthesis does is it takes lots of different films from different angles and it puts it together and you get more of a 3D picture of the breast. And also get your mammogram in the second half, in the luteal phase of your cycle. If you're not menopausal yet, get it in the luteal phase so there's going to be less estrogen and more progesterone. And if you have breast dense tissue, ask for an ultrasound because that can still be screening and it can be helpful. Bring your old films with you to your radiologist's office, because really when they're doing their first mammogram on you and they have nothing to compare it with, they're more likely to be overcompensating and thinking that there's something abnormal. So bring your old films so they don't have to wait and get them from, call them and get them from your other place. If you can get them, bring them with you. And if you're at increased risk, if you're obese, you smoke, you have a family history of breast cancer or some other cancers too, then you might need to have more screening. So, and you can check your own risk. How can you check your risk? Because you might need an MRI. So there is a breast cancer risk assessment tool, and it's based on a statistical model. It's called the Gale model. The NCI, National Cancer Institute Division of Cancer Epidemiology and Genetics has it, but it may underestimate the risk of Black and African-American women, and it needs a little more validation in Hispanic women born outside the US, but the Gale model is still pretty much the gold standard. We do use it a lot. If women have a history of something called lobular carcinoma in situ, they can use something called the IBIS, Breast Cancer Risk Evaluation Tool, IBIS. And if you have a known mutation in any of the genes that cause the inability to repair DNA, like the BRCA1 or BRCA2 gene, you can use something called the Boadicea model. It's BOADICEA model to estimate your breast cancer risk. And certainly if you have a breast cancer risk that's determined by any of these models to be over 20%, you should get the MRI. Get the MRI with contrast. I'm sorry, it has to be with IV contrast, which has its own dangers. So ask for the macrocyclic gadolinium, which has the least brain accumulation. It's used with mammograms, and sometimes it's done every 6 months. So you'll have your mammogram, let's say in December, and then maybe in June, you'll have your MRI. It may replace sonogram, so there's no reason to get the ultrasound along with the MRI. And it is recommended if your lifetime risk is greater than 20% by the Gale or any other model. When you get your MRI, you want to do it on day 7 to 10 of your cycle, and also be off. So that's different from the mammogram, which you would get much later in your cycle, and be off hormone replacement therapy. If you are postmenopausal on hormone replacement therapy, you should be off hormone replacement therapy for 3 weeks before you get your MRI. If you have a genetic mutation, if you carry a genetic mutation that makes you more likely to have a kind of a cancer. Sometimes they're cancers of the breast, sometimes they're ovarian cancer, sometimes you have something called a Lynch syndrome, and you're more likely to get other kinds of cancers. And that kind of risk determination is done by a genetic counselor. So if you have a strong family history of cancer, especially premenopausal cancers, definitely talk to your doctor about being sent to a genetic counselor so you can determine if you are high risk for breast cancer, and you should have you should start getting early MRIs. And there are various ages when we would start MRIs.
Well, Debra, you are a fount of information, honestly.
This was helpful.
Amazing. Absolutely amazing.
Thank you. Thank you very much. I'm glad that I was able to give this information, because boy, my head was exploding when I first heard that MRIs were not, that mammograms were not the panacea for women. This is the gold standard. You started, I told thousands of women to get their MRIs regularly. And
well, this is why we're doing this.
Yes.
Because we want to come back and we want to fix, what we've done in the past, but our whole objective is to get women to change their health destiny, especially before they get pregnant, because that's one of the big things, because we want to help change the next generation. You saw them coming out the chute. I saw them when they were big and grown, and I was trying to teach them. And wow, what a difference in our children. So we want our children to be as healthy as possible. And it starts with you having a healthy body. So hopefully we'll see you guys next week. And if you have questions you want us to answer, please always do. You can connect with Debra and I either through the pregnancyadvantage.net or through A New View of Food or Simply Plant-Based. Any one of those, you can find us. We're all on Facebook. So thank you for joining us today, and we'll see you next week.
Thank you, everyone. Thank you.
Bye-bye.
Bye-bye.